We are pleased today to introduce Dr. Nada Fadl to present in our Sudanese Infectious Disease Association Infectious Disease Grand Round. She'll talk about HIV resistance and the challenge still exists. The floor is yours, Nada. Welcome.
Assalamu alaikum. Shukran jazilan, عز الدين. Thank you everyone for joining and for all those who are listening to us today. الtopic بتاعنا الليلة هيكون as عز الدين mentioned, HIV resistance, the challenge still exists. My name is Nada Fadl. I'm Professor of Infectious Diseases and Medical Director of the Specialty Care Center, which houses our HIV programs, and Assistant Dean of Inclusive Education at University of Nebraska Medical Center. So thank you so much for having me today. All right, let me know if you see the slides, if you can hear me, and everything is good to go. طيب, so generally the objectives of this talk, just to focus mostly on clinically how HIV resistance has evolved by understanding the principles of HIV drug resistance, the changes that happened over time, and what do we focus now on the era of modern ART, including long-acting injectable. I left a lot of room for discussion, for case-focused discussion so that we can exchange knowledge and practices, because a lot of these things there is no right or wrong answer to. It's just different types of approaches and practices depending on the clinical setting, depending on what's available, and depending on how people approach this problem in general. So there's a lot of abbreviations. Just wanted to give people heads up about these abbreviations. I think most of us are familiar with them, but just in case, ART is antiretroviral therapy, INSTI, integrase strand transfer inhibitor, NNRTI, nucleoside or non-nucleoside reverse transcriptase inhibitor, NRTI, or nucleoside reverse transcriptase inhibitor, protease inhibitor is PI, DRM is drug-resistant mutation, PDR is pre-treatment drug resistance, and TDR is transmitted drug resistance. And we'll talk later about the difference between the two, between pre-treatment and transmitted drug resistance. So why does resistance matter? Resistance matters because it leads to worse treatment outcomes, and it limits the options of available ART for patients. So it makes the treatment much more complicated, and it makes the chances of them achieving virological suppression lower if they have a multi-drug resistant virus. And it's really a symptom of deeply rooted issues related to social drivers of health. So resistance should not be just taken as the patient is not adherent to their medicine, they don't take them, they're non-compliant, all these labels we give to patients, but it's rather a manifestation of problems with the system itself, that patients are not able to access health, they're not able to access good antiretroviral therapy, and they're not able to process through the system to be able to get it. And as we all know, resistance can also lead to transmission of drug resistance virus in the community, which then becomes a bigger problem because the patients who are coming in treatment naive, they will come in with drug resistant virus. So that makes it even much more complicated to start somebody on medications while they're treatment resistant. So these are the main challenges. There's so many others that I didn't want to go into, but just in general, these are the important challenges that should come to mind when we talk about resistance. That's why it's still relevant and still an issue. So what are drug resistance mutations? These are specific mutations in the HIV genome that are associated with reduced in vitro and as well in vivo activity of antiretroviral drugs. Now, these are class specific usually, and they generally emerge in the gene, which is targeted by the specific drug, such as the reverse transcriptase gene, the protease gene, the integrase gene. So they emerge in those genes, and then they don't cross-react with other genes. So if you have the same number mutation on one gene, it doesn't mean it infers resistance to a drug in a different class than the gene targeted by that class. So they're generally divided into two, acquired drug resistance, which by the name, this is selected during antiretroviral therapy. It happens over time. And transmitted drug resistance, in which the patient acquires a virus that's resistant. And these are generally naive patients that have never been on treatment, they're newly diagnosed, and we're pretty sure that this is a transmitted drug resistance. So these are the general two classification. Let's start by transmitted drug resistance. This is actually becoming maybe lesser of an issue in terms of quantity, but more of an issue in terms of quality, if we can name it that way. And the reason I'm saying this is that now the drugs that you can become resistant to and acquire transmitted drug resistance, they can go all the way to integrase, which becomes a big problem if somebody acquires transmitted drug resistance to integrase, which is luckily extremely rare right now. So generally in the population, this is about 2 to 15%. It varies quite a bit by the region. The geographic regions in the country, which have much higher rates of transmitted drug resistance, there are geographic regions which have lower rate, and those also correspond to the rate of HIV control in the region. Obviously, if HIV is well controlled, the viral suppression is high in that region, there is less likely to transmit drug that is resistant. But if there is higher rates of lack of virological suppression, then there is a lot of virus that circulates in the region that can be transmitted. It also depends on the sexual networks in the region. The tighter the sexual networks, the higher the likelihood that the transmitted drug resistance is going to occur. In some regions there, though, it's hard to ascertain if the drug-resistant mutation is transmitted or happened due to prior exposure to ART. And this actually happens quite a bit in low-middle income countries, where patients move from one clinic to another, from one region to another, and they do not disclose that they actually do have HIV and they were on prior ART due to stigma. They're afraid to face stigma in that clinic. So the patient comes in, they get tested all over again, and they're assumed to be duly diagnosed. And when they test for mutations, or sometimes when they start them on drugs and later test for mutations, they identify that this patient actually does have what appears to be transmitted drug resistance, but in fact, it's actually not a transmitted drug resistance. That's why the name pre-treatment resistant emerged in some low-middle income countries to describe this phenomena, because they cannot 100% say that this is a transmitted drug resistance. So that's why they call, in some places, you'll see in the literature, it's mentioned pre-treatment drug resistance, which could be transmitted or could be that the patient just didn't disclose that they had HIV and they have been on ART prior to that. Generally speaking, with transmitted drug resistance, you get one drug resistance mutation transmitted, usually in one gene. Sometimes it can be 2 or 3 mutations, but also they usually happen in one gene. Most commonly, those are NNRTI. So we might all remember K103N, which conveys resistance to efavirenz, to nevirapine, and that can be one of the early transmitted drug resistance mutations if somebody fails efavirenz. The other common ones are the NRTIs, and one of the most common ones is the M184V, which conveys resistance to lamivudine and emtricitabine. So those are usually the ones we see and the ones we are more familiar with. Now, as I mentioned, integrase is extremely rare, but it can happen and it's being described, so something to be very careful about. Again, sometimes it could be just pre-treatment drug resistance, and we don't know. And we'll talk about that later, actually. Now, there are mutations that have low fitness cost, and these are more likely to be detected. What does that mean? Does that mean that the mutation does not actually affect the replication of the virus? So if somebody could be muted, please. So the mutation does not affect the fitness of the virus. So the virus is still able to replicate in spite of the presence of that mutation, which leads us to be able to detect the virus as replicating with that mutation, right? Now, there are mutations which cost fitness to the virus. They cause the virus to be less likely to replicate. And those are less likely to be detected because that virus kind of dies or gets overcome by the wild type virus. So we're less likely to detect that mutation. Now, one of the mutations that we're able to detect because it doesn't cost fitness to the virus is a K103N, as I mentioned earlier. So what causes resistance? The answer is simple. Simple yet complicated, honestly, but it's adherence. 90% of the time, 99% of the time, I should say, is adherence. Now, the drivers of adherence could be complex and complicated, but that's the bottom line. You know, many patients say, no, I'm taking my medicine, I take them every day, but then reality is you're not. For some reason, it could be that you're forgetting them. It could be that you have neurocognitive disorder due to HIV and you think you're taking them. But regardless, adherence is the reason why people develop drug resistance, because basically mutations are replications dependent, and they do lead to genetic diversity in the virus. So the more the virus is replicating in presence of drug, the more likely that the virus is going to become resistant. So, and that presence of drug leads to selective pressure of drug-resistant virus, right? Which makes sense. If there is low levels of the drug, then you get to select for that drug-resistant virus, which then emerges as the most dominant virus. And this selective drug resistance can emerge as actually very low levels of HIV replications. Some people think this can happen in the range of 50 to 200 copies. Even with that low level, which we usually think about as low level viremia, you may get to be able to select for that drug resistance virus that could be present at very low quantities, but because of the presence of the drug at subtherapeutic levels, not being able to completely kill this virus, then you get to select for that resistance, and then it becomes the most dominant virus in the bloodstream. Now, most people think that you need a higher level of HIV virus in the blood to be able to select for a drug resistance virus, but nonetheless, it can happen in vitro, at least at that low level. But generally speaking, the higher the viremia, when you get to 1,000 copies per ml, and you have low levels of drug or subtherapeutic levels of drug because of low adherence, then there's no doubt that at that level, you'll be able to select for resistance, especially for drugs which have what we call low barrier to resistance. If you just need one mutation to become resistant to that drug, then you're most likely going to select for resistance to that specific drug. So the question is that how do we know that there is drug resistance? You know, if somebody has some low level of viremia, it's creeping over time. What do we do in that case? Do we get drug resistance or not? So the way to check for this, obviously, is to get either a genotype or a phenotype. Genotypic resistance testing is the most common one that we get nowadays. We rarely ever get phenotypic resistance testing. And generally speaking, is if the patient comes in newly diagnosed and they have signs and symptoms of acute HIV, we should obtain the resistance testing right there and then. But that should not delay us before we start the antiretroviral therapy, because we know now from multiple studies that starting patients on acute HIV on ART immediately restores their immune function, leads to better virological outcomes long term. It leads to lower transmission of that virus because usually they have copies in the millions. So you get the resistance testing, but you should start ART right away. You don't wait for the results. And now, generally speaking, actually with rapid start movement, we don't wait for resistance testing because the drugs we have right now available, they're very potent and they will work even with lower levels of resistance for NRTI, for example. Now, chronic HIV, if somebody comes in, again, diagnosed years ago, as I mentioned, you don't wait for the resistance result, but you should obtain resistance testing before starting patients on ART, just because you want to make sure this patient does not have transmitted drug resistance, and you want to have a baseline. In the future, if the patient starts, having problems with adherence and they do not do well on ART, then you want to have that baseline available. If you don't have baseline, it makes things really difficult to interpret, honestly. In cases of virological failure, you should obtain resistant testing with confirmed virological failure. And generally, confirmed virological failure is 2 viral loads that are high. Depending on your threshold, some countries use 200, some countries use 1,000. But generally, if there are two high levels that are confirmed, then you should go ahead and get resistance testing. And if somebody has suboptimal suppression, they're not yet completely failing, but then they fail, and then they do well, and then they fail again, and then they do well. And we see all of those patients in the clinic all the time. You talk to them about, you take your medicine, you have to take your medicine. They start taking the medicine, you bring them back in 4 weeks, they're undetectable, but then you meet them again in 3 months, they're detectable again. In that case, don't wait. Just go ahead and get the genotype at that time, because they had already failed in the past and now they're failing again. So that's kind of, even though it's not back to back right away, they have this consistent history of suboptimal suppression. Now, pregnant people, before you start ART, you should get resistance testing. Again, don't delay starting ART. If they become detectable while pregnant, it's also recommended to get a genotype. Don't wait, don't hesitate, because that's a very critical situation. You want to make 100% sure that this woman does not have resistance in her virus. Now, there is a lot of debate, still controversy. I thought by this time this would be solved in the literature, honestly, when it first came out more than 10 years ago, about proviral DNA resistance testing, or what we call archived genotype or GenoSure archive. It's still relevant, but it's not really clear how relevant it is, honestly. Or is it like, it should be taken with caution, I should say, if you get those results. But generally speaking, if the virus is, it should say undetectable. If you have a patient with undetectable virus and you try to switch the regimen, but you're worried about the regimen you're going to switch them to. A very good example of that comes when we switch patients to dual therapy, two-drug therapy, dolutegravir, emtricitabine, because they have, you know, bone or renal issues, or dolutegravir, rilpivirine. Both emtricitabine or lamivudine and rilpivirine have very low barrier to resistance. So if the patient has mutations to those, you end up treating them only with dolutegravir. So in that case, you're really worried. You want to make sure that this patient is not resistant to the other drug, to the lamivudine or to the rilpivirine. So some people argue in that case, if you suspect this patient might have been on these medications in the past, or they've had history of non-adherence in the past, then you should probably get an archive genotype to make sure. Now, if the archive doesn't show that resistance, does it mean it never happened? Or does it mean it just didn't get archived? The jury's still out, honestly, on that. But if it's there, then that's helpful. If you find somebody has a rilpivirine mutation in their archive genotype, then you should probably not put them on rilpivirine containing agent. So that's just kind of how it can help you. But sometimes it doesn't help you. Sometimes it causes more confusion because then patients are doing fine, but then they have this archive mutation. What do we do about that? So anyway, so it's something to be available. I would really consult somebody who has HIV management experience before getting archived genotype. So if you don't treat HIV on a regular basis and you come to a situation where you think you might need to check an archive, consult somebody who does this on a regular basis. The last one is phenotypic testing. And this is really rarely ever used nowadays. I think in the future, we may resort to it more once we get complex resistance to NSTIDs and others. But right now, we don't really use it unless the patient has very complicated history of PI resistance. For example, darunavir, you have 10 mutations to darunavir. If you get 3 out of 10, then you have a higher chance of becoming resistant. But to become completely resistant to darunavir, you need 7 out of 10, right? So how do you interpret those mutations? Is it causing some resistance, high level of resistance? Some of them have more weight than others. So in order to interpret that, you can probably, that would be a perfect situation to get a phenotype, because that will tell you phenotypically how does the virus behave to this drug. And it's a very complicated test. So not complicated in the sense that, it's not as easy as the archive, because it's not just kind of machine run and interpret it nowadays. So interpretation, now going into that. So there's kind of 2 major ways of interpretation. The most familiar one to most of us is the rule-based. And this is basically an analysis that requires analysis of what's happening out in the literature. And an example of this would be the Stanford database for drug resistance. This is a rule-based resistance system. You enter your mutations. It kind of analyzes what's in the literature, and it gives you an interpretation of what does this mutation do to this virus, right? You select multiple mutations. Again, it looks at the rules in the literature that's already in the database, and it analyzes them accordingly. So basically, the rule-based system is extremely important. It's very helpful, but you have to add that with your own clinical interpretation, because sometimes the rule-based doesn't really make sense with what you're seeing clinically. So you have to understand if the patient history is consistent with the rule-based system. And honestly, in those cases, most of the time I had to go back and ask the patient questions to identify gaps in the history. So it's not that the rule-based system was wrong, but I did not get this history from the patient that they were in California before and they got on ART for 6 months and then they stopped, et cetera, et cetera. So those things sometimes emerge after you ask questions. And then one other thing is that keep in mind that the rule-based system might not be able to tell you that this is resistance, because it could be happening at low level. It did not emerge as a mutation. So you input things, the system says, yeah, this medication is, can work in this patient. Then you go ahead and start the medication. Later they fail. It's not that the system was wrong. It's just that the low levels of detection did not reach like 20% level for the genotype to be able to detect that mutation. And virologic failure of first-line regimen typically involves when HIV isolates was resistant to only 1 or 2 drugs at the most. You rarely fail the first time with pan resistance or multi-drug resistance. If that's happened, that means we missed the ball at some point. As I mentioned, either the patient was on drugs before, or we waited way too long to actually get the resistance testing. So generally speaking, the first time we get to resistance testing, usually there is 1 or 2 drug-resistant mutation. There'll be a lot of phenotypic abnormalities because, as we know, the reverse transcriptase is error-prone. It replicates fast. It replicates with a lot of errors. So you'll find tons of mutations. But the drug resistance mutation to the regimen that the patient is taking usually happen at 1 or 2 locations. If you find there's multiple drug resistant mutation, you have to question yourself. Either the patient was on something before, or the patient has waited way too long before you actually tested them, or they were not adherent, it just didn't tell you. Then again, you have to also think about this system when you're interpreting it. Does the patient have a drug that has low barrier to resistance or high barrier to resistance, even in the same class? If you're talking about integrase, for example, if the patient is on raltegravir, is much different if the patient is on bictegravir. Raltegravir is a very low barrier to resistance. It takes 1 mutation to knock the drug out. Bictegravir, on the other hand, is a high barrier to resistance. It's a pathway before the patient becomes completely resistant. So then you have to kind of weigh that in mind. If the patient was on raltegravir in the past, you probably should be cautious if they fail that before you give them bictegravir. So the other system is a machine learning system. We haven't talked about that. That's basically AI-based. And usually now it's in research settings. It's not available widely for public use, but that's, I think, is going to be the future. It's going to be, how do you use AI to interpret these mutations? And I think that's kind of, whether we like it or not, that's the future of a lot of things in medicine. So we should be ready for that. Now, absence of resistance. This is another kind of fun topic that happens a lot. Does not rule out presence of drug-resistant virus. And the reason that happens is that it could be the drug-resistant virus was present in low quantities, less than 20% of the populations. What we call the minority viral subpopulation. If it's present in those low quantities, it's not going to be detected by the genotypic resistance testing. It could also be that the patient discontinued ART much longer than when you got the resistance testing. Generally speaking, if there is a month interval between discontinuation of ART and obtaining of the drug resistance, the wild type, because the wild type is much more fit than other types, most of the time, then it starts replicating and it overtakes the population that's present. So you're not able to detect the drug that's resistant. And this happens a lot, actually. People will tell you, no, I've been taking it. I've took it like until last week, or 2 weeks ago, I was taking it. And then you go ahead and you check the resistance testing and it becomes completely normal. And you're like, that doesn't make any sense. They're failing and they continue to fail, but then they're not resistant. In that case, you really have to question if the patient was taking the medication at the time you checked the drug resistance. Lab error, occasionally that happens. A couple of cases we had to call Monogram and said, hey, are you sure, is this the right specimen, etc. And even though it's extremely rare, but that does happen. And just sometimes we just don't know. We see these mutations, we think of them as phenotypes, and then in the future, once the science emerges, we would know that these actually do cause some drug resistance. And we learned about drug resistance this way, right? We did see these changes in the genotype of the virus, and then we later learned that these are actually not just changes, these are drug-resistant mutations. So the field is evolving, especially with newer drugs emerging. Sometimes the region that's targeted by the assay goes up to a certain region in the virus or in the gene, because that's where we know drug resistance occur, but it may occasionally fall within or outside of that region. So theoretically, that can happen. And sometimes drug interactions, even though we think the drug is present at therapeutic levels that can lead to selection pressure or selective pressure, it could be that the patient is taking some other drugs that is causing interaction at that time. So just keep all of these things in mind. Okay. All right, so we'll go to a case now, and I really would like to hear from you guys. So I'm not speaking to myself the whole time. And if you don't want to speak for whatever reason, put it in the chat, but please unmute and give your opinion, because I would really like to hear about your opinion about these. And these are real life cases. Actually, both of them happened in our clinic in the past year, so somewhat fresh. So just in general, very quick review for those of you who don't treat HIV. This is what a mutation looks like. This is from the 2022 IS mutation update. So basically, the first letter is the amino acid location in the amino acid in the wild type. The second letter that comes after the number is the substitution that confers resistance. And the number is where that substitution or insertion happened. So K65R, this means the original amino acid was K and it happened at position 65 and it got replaced by R. And there is obviously a list of what these abbreviations mean for amino acids. I'm not really the best at memorizing these, but if you want to know the exact name of the amino acid, then you could go to that list and figure out what that is. But generally speaking, that's how we describe it. The second letter is a substitution, right? So this is a 34-year-old. He was initially diagnosed with HIV and PJB in the late fall of 2002. He established care in our clinic in December 2022 and came in as a newly diagnosed patient with advanced HIV, obviously, PJB as his presentation. His baseline HIV RNA was almost 500,000 copies. His baseline genotype had K103N, had 106, has Y181V, I think, or I, and all other classes were susceptible. But this is an NRTI class, and we'll show that later. He did have at least 3 mutations in the NNRTI class. His baseline CD4 count was 6, percentage was 3. So he was extremely advanced HIV, right? So based on this, obviously, we are not going to use an NNRTI class nowadays anyway. It's not the preferred in the guidelines. He should do very well on Victegravir, tenofovir alafenamide, emtricitabine, and that's what he was prescribed. He was prescribed Biktarvy or VFTAF, and he was given Bactrim for PJB prophylaxis. He didn't have insurance right away. This is December. Again, lots of social issues, social drivers of health, like we mentioned earlier. He didn't have ADAP because he had income. So he was above the income for ADAP, but not yet able to get insurance. It was complicated as usual. So his ART start was delayed until April 2023. So few months before he started ART, but starting in April 2023, came back in May. A month later, his vital load was down from 473,000 to 632 copies. So substantial decrease, more than 2 log drop in his vital load, which was really great and kind of what expected to be seen in about a month. Most time people are undetectable, but that's very acceptable as well. Came in June, and his vital load has dropped further. Now, 2 months later, usually we see undetectable, but it still has dropped again 1 log, and his CD4 count has increased to 160. Now it's 13% instead of 3%. They kind of decided that, yeah, it's almost undetectable. He demonstrated over 2 months that he's undetectable. So let's stop Bactrim. I probably wouldn't have done it, but nonetheless, they stopped the Bactrim. Now, in July, he came in, and this is a patient we were keeping close eye on him. He came in again, and his vital load had spiked to 10,000. So from 200 copies went to 10,000. This is clear failure at this point. And he said he only missed 3 doses of medications. He had a short incarceration during the summer, but, was released right away. But while incarcerated, he didn't take his medication. So that was a shock. We were like, oh my God, we usually get the labs after the patient comes to the clinic. So we got the lab result, took maybe a week, got hold of him. You need to come back to get resistance testing. He came back a month later. And at that time, we did a resistance testing. His vital load was about 7,000 copies. So kind of around the same. And he had this basically kind of MDR, I want to say TB, MDR HIV. So he had multiple insertions or mutations at the INSTI gene, and he had still susceptible virus in the NRTI or in RT region, mostly susceptible, just one M184V, that was the only one. But he did have, PI was susceptible, but NRTI had 184 and 65. and NRTI, he still had those mutations he came in with in the beginning. And these are mutations that doesn't cause fitness cost to the virus. That's why we're still able to find them, even though he's not been on NRTI, but those kind of carry along and they're still present as the virus replicates. So we're just going to show a graph before we go to analyzing his resistance, but this is how integrase class differ in terms of the weight of the mutation on the fold increase in resistance. So as you can see raltegravir, abacavir, they have very low barrier to resistance. It takes the same concentration to cause much higher fold increase in resistance or in resistance versus what happens to dolutegravir and bictegravir. So the same concentration can cause much more resistance to raltegravir and abacavir compared to the newer generation. And it's shown here in the median. So if you want to look at this table and focus on the median here, you can see big dolutegravir, abacavir, and raltegravir, and the median fold change versus wild type is 2 for bictegravir, 3.4 for dolutegravir, not much different. And you could argue that cabotegravir, the newer generation injectable, is somewhat closer to these two. But if you look at elvitegravir and raltegravir, the fold change is much, much higher, more than 10 times almost. So that's, or actually, closer to 100 times. So this is much different. So that means if you have one of these resistance, which are, you can't see them here, but they're listed down here in the y-axis, or the x-axis, is that you can see the mutations listed, and this is the fold change here in the y-axis. So keep that in mind, that even within the same class, sometimes it takes 2 to 3 mutations. But in this case of this patient, this is what his analysis based on the IAS chart. This is a very easy to carry pocket card. I usually print it and fold it and put it in my pocket. It's very nice to go and analyze things yourself and then use the Stanford database to see if your analysis was somewhat close to correct. And it's kind of nice to do it that way, because then you train your brain to try to analyze these resistance. So he has a K65R. We know this is a signature mutation for tenofovir, meaning presence of tenofovir is what selected for this mutation, but it also causes fold change to abacavir and emtricitabine. It does not impact zidovudine. Actually, zidovudine has increased sensitivity in presence of K65R, but nobody uses zidovudine these days, obviously. M184V, on the other hand, it's a signature mutation for emtricitabine and lamivudine. It does cause partial resistance to abacavir, but not by itself. You need another mutation, the L74V, which is signature mutation to abacavir. But nonetheless, his NRTI class, you can see that tenofovir is pretty much knocked out, and emtricitabine, lamivudine are impacted. But M184V is one of those mutations, the favorable mutations that we like to have, because it decreases the fitness of the virus as well. So this is not a bad thing, right? Same thing with the NRTI. I'm going to just mention these and then wait for you guys to talk about the integrase. So this is, it pretty much knocked all the class, even doravirine, the 106 affect doravirine. You have efavirenz. He came in with efavirenz and multi-drug resistance mutation in the same class. So these were existent beforehand. So you really don't have any choices within that class, unfortunately. And this becomes important if we were switching his regimen to a newer class. It would be really nice to have doravirine, because that's a sturdy drug. He only has one mutation to doravirine, which is reassuring, but this will cause partial resistance. So you don't want to take that risk, obviously, with him, with knowing his adherence is a problem. And this is the integrase class. Things kind of got out of place, but he has a 66 mutation and has, let's go back, 66 and 138, 140, 147, and 263, which are all very significant mutations when it comes to bictegravir and also cabotegravir to some extent, because you have these mutations here as well. So having thought about this in his case, let's go back to the case. This is a newly diagnosed patient, comes in with a very high virus, gets started on appropriate therapy, something that should work in presence of NRTI mutations, suppresses in the beginning, right? Seemingly doing okay. And then for no reason, in a very short period of time, just 1 month, he spikes up to 10,000, saying that he only missed 3 doses of drugs, right? And that's confirmed because a month later, he's still not suppressed and now has multi-drug resistance mutations. So I want to hear from you guys what your thoughts about this case. I guess the first question, does this make sense? Does the story make sense?
No, I think unless he misses longer periods of time or something, it's just too quick.
Yep, 100% agree. We don't see this, nowadays you suppress, you stay suppressed, you miss 3 doses, bictegravir is very forgiving. You probably do okay, you go back and you take it and you do fine, especially if it was like just one interruption because you went into jail, you miss those 3 doses. If you're missing 3 doses every week, that's a different story, obviously, right? What else are you guys thinking about? So, I mean, keep in mind that there was a kind of a big gap between his diagnosis and the time we saw him. There were about maybe almost 6 months before we saw him for the first time. And he was hospitalized for PJB. And nowadays, the general approach is that if you hospitalize with HIV presenting disease, illness, unless it's cryptococcal meningitis, you get started on ART right away, right? So the story just kind of didn't make sense that he never got started on ART in the first place, right? So that's what we went back and we're like, okay, let's double check this. We got his records from the other hospital because initially we just took his word of mouth, and it turned out that he was actually started on Genvoya at that time, and he took it for a short period of time, did not take it very adherently because he also had insurance problems. He was moving. It was kind of a chaos in his life. He was sick. So he was just not really that good at taking it. And that's probably what precipitated some of these integrase mutations. So it kind of made sense then that he did go and have an M184V and K65R. Now, the M184V could have also been transmitted because he did have a lot of NNRTI mutations. So it could very well be that he had an M184V, but it was not detected at the time because it does fitness cost to the virus, right? But the K65R, he had to be on tenofovir before. And it doesn't make sense in a month to develop that. So he probably had that coming in. And then when we started him on bictegravir, he already had NRTI mutations. So it's easy for him to become resistant to integrase. And it could have very well been that he developed some of those before when he was on Genvoya, which is the elvitegravir that I showed you in the chart here. So elvitegravir, it doesn't take much to change the resistance, even with one single mutation. It's very easy to make multiple fold changes. I mean, here, this is a single mutations here, right? Then here you have 2 mutations. And then as you go in the chart, you have 3 mutations. So the more mutations you accumulate, you're likely to become resistant to bictegravir and dolutegravir. But even then, the change in the fold does not match what happens with raltegravir and elvitegravir. But even with single mutations, you can become resistant to elvitegravir. It has a very low barrier to resistance, right? So it just takes the E92 or it takes the 97 or the 121, one of those mutations that can knock the drug out. So that's probably what happened in his case. He was on the elvitegravir. He already had one of these mutations. And on bictegravir, he accumulated a second and third, and that's how he became resistant to bictegravir. Okay, so now the question is what to do now. So we have somebody who has NRTI, NNRTI, and integrase resistance. So anyone wants to take a shot at what to do with him? I'm really curious to hear about also people not from the US, because in the US kind of it became prescriptive, honestly, like, feels this, you go to this, so to speak. But in other countries, sometimes things are done a little differently. And when I presented this at ASM is an international conference. So there was somebody from the UK who actually challenged what I suggested or what we had done. Is like, I wouldn't have done that. I would have just waited. And that's for the second case. Well, not this case, but we'll talk about that later. So anyone wants to take a shot? There is no wrong answer, Jamal.
With the PI, maybe? I don't know.
Yeah, definitely. Definitely. PI, there's no resistance to PI, there's no exposure to PI. So PI class is perfect, right? So that's one of the few situations nowadays we end up using PI classes, right? So he can certainly be on a PI. That would be perfectly fine.
Can you give it alone though?
Yes,
Or
Nidal, go ahead.
I mean, can you give a PI alone, or do you have
Oh,
to
sorry. No,
approach?
of course you can't, right? So you cannot use PI alone, but we know that PI is going to be in that regimen.
These are the other ones, the fusion inhibitors.
Yeah, so then you have to think about outside of these classes, right? So INSTI is pretty much shut down. You can't use INSTI, even though some people might argue you can use dolutegravir BID. There's still room there, maybe not. It's just that we didn't feel that it's worth taking the risk. But you want to use some other newer drug. And in this case, actually, we chose to use fostemsavir, which is now FDA approved for multi-drug resistant virus. Even this, is two classes. It's not completely multi-drug resistance, but at least we can save the PI. So he switched to darunavir, boosted darunavir with cobicistat, and fostemsavir. So, and that's what we found, that, as I mentioned, that he had prior exposure to albitegravir. Unfortunately, we don't know what happened to him. I mean, ideally, he should take this medication. He's suppressed, but he has not had a follow-up to date. This is more, now it's coming closer to a year, and we haven't seen him. And he's not alone, unfortunately. There's only 65% of US patients living with HIV are virologically suppressed. That means 35% out there are not virologically suppressed. And these are patients who carry resistance and transmitting resistance. So this is going to be just kind of going into circles for a very long time before we're able to control or avoid completely multi-drug resistant virus, unfortunately. So we don't know where he has gone. We don't know if he has moved, if he's incarcerated. Nobody was able to track him down, even though our case managers go on Facebook and they go on social media, they text. They just could not find him or know what has happened to him. So
Can you give us a brief background on fostemsavir?
Yeah, actually, I have a slide later, so we'll talk about that just in a minute. But yeah, that's a good point. And fostemsavir and then lenacapavir. I did not include lenacapavir here, but that's the other drug that's now FDA approved for, and actually has a really good future for PrEP as well. And we'll talk about that, even though I didn't include the slide. And then the third one is ibalizumab, which is a monoclonal antibody. There's more drugs coming in the pipeline, but those are the three available right now in the US. Okay, sounds good. So the other case that I wanted to bring up, because this is now an issue, it's becoming more of a challenge than a convenience, like we thought it was going to be when it came out, is the long-acting injectable cabotegravir rilpivirine. So I mentioned this, I think, a few times before, that rilpivirine has a low barrier to resistance. Rilpivirine has a lot of barrier to resistance. Rilpivirine has a low barrier to resistance. So if you end up using something that has resistance to rilpivirine, you end up treating with the other drugs. So cabotegravir rilpivirine is dual therapy. It's only two drugs, right? So if the virus is resistant to rilpivirine, then you're treating them with only cabotegravir. And the challenge nowadays, most of the patients we switch to cabotegravir rilpivirine, they're not on rilpivirine containing regimens when we switch them. They most likely are on integrase regimen. So at the time we switch them, they're suppressed. They have to be suppressed per the guidelines now, even though the future might change. So unless you have a really good history of whether this patient was on rilpivirine before, you might not get to know that. And the patient we just talked about, he had inherent drug-resistant mutations, transmitted drug-resistant mutations that would have prevented him, but we wouldn't have known that unless we got that genotype, right? So as you remember, we said earlier, if the drug-resistant virus constitute less than 10 to 20% of circulating virus, you might not be able to detect it by commercially available assays, which is a challenge, right? Now, wild-type virus often reemerges as the predominant subpopulation after you stop medication. So if you get the resistance testing a month after you stop is probably going to be wild type virus. So it's not 100% reliable unless you know that you got it at the right time for the right patient. And in the setting of virologic failure, we know that we should perform the resistance within 4 weeks, within the first 4 weeks, while the patient is failing. But if the patient is undetectable, then that becomes a challenge. When do you test them and how do you test them? Because they have controlled virus, they don't have any viremia in the blood, because you really need around 500 copies for the monogram assay to be able to detect resistance. Anything less than 500 copies per ml, they're not going to be able to run the assay, and they will return the results saying there is not enough virus. In some research settings, they can detect it with 200 copies, but now in the commercial setting, it's only 500. Now, with long-acting injectables, remember that the drug pressure may persist for a prolonged period of time, which creates a challenge when we're checking for resistance, right? Because if you stop the drug is present in there for technically up to 2 months at therapeutic levels above the IC50, right? So in some settings, this is where the proviral DNA resistance testing could be an option, especially if we're trying to change somebody to long-acting, and we don't know if they had a prior exposure to NNRTIs. I rarely worry about INSTI exposure because most of the time we're switching somebody from INSTI. And if they're controlled on bictegravir, they're going to be controlled on cabotegravir. But the NNRTI exposure is usually something that we don't know. It's hard to find in history. The prior genotypes could have been fine, but yet the patient might have harbored some archived drug resistance to NNRTI. And this is what's shown to predict failure in clinical trials. They found that people who had baseline NNRTI resistance in their archived DNA ended up failing the drug. So that's something you definitely want to check and make sure that that doesn't exist. So we have a case here, and then as I mentioned, I'll talk a little bit about fostemsavir, and then we can talk about lenacapavir. And I see Yusri is joined now. So Yusri, the expert is in the house, so he can also answer any questions that we have. So this is a patient. The question came up to me from one of our junior faculty. It's like, what do you do? Should I keep him on cabotegravir or rilpivirine? So this is a 49-year-old male. He was seen in our clinic for the first time. This was like literally a couple of months ago. He was transferring from another clinic. He was managed at that clinic for years and decades. He loved that provider, but the provider retired, and he decided to switch to our clinic. So he was diagnosed with HIV in 2000. He was started on ART shortly thereafter. He's been on many medications and has extensive resistance. That's what he told us himself when we asked him questions. He's like, oh yeah, I've been on so many medications. Like, oh my God, I remember all those things, at the time, AZT and all that stuff. And yes, I had so many resistance. I was not good at taking my medicine, but I'm much better now. I'm older. I learned my lesson. So at some point, his provider decided to switch him to cabotegravir rilpivirine in September of last year. And when we looked in his record, in the other provider record, we actually found a genotype that other provider obtained. And the genotype showed E157Q and N155H mutations that convey partial resistance to cabotegravir. And you can see them here. This is the N155. It's usually something very concerning. It's kind of a pathway to resistance. And when you get to N155, you kind of worry. And he has the 157Q2, which is not shown here. So he's suppressed, though. He's suppressed on long-acting cabotegravir rilpivirine. He's getting it every 2 months. He does not have obesity, does not have any other drug interactions, like the other factors that you worry about that may change the concentration of cabotegravir rilpivirine. They're not there. So the question came up, okay, we know this guy had these pre-existing mutations. We know that something happened. This is 2013. We're talking about more than 10 years later, or 10 years later when he was switched. We don't know what happened in those 10 years. We don't have a genotype showing if he actually accumulated more integrase resistance in that time. But now he's suppressed, even in spite of presence of these resistance. So the question came, should we keep him on cabotegravir rilpivirine? And these are obviously kind of the practical questions we asked. Do we keep him? Do we switch him? What do we switch him to? Do we get an archive testing? What do we do at this point? And I would really like to hear from the audience. Again, I brought this to the conference, to ASM audience, as like, we just don't really know. This is more about like feeling, so to speak, rather than complete true science, honestly. So I would love to hear what people would do. And if you have something to do, because sometimes you might not have any other options and just you're stuck. Okay, so I see something. Okay, how many years he's been on? So less than a year, because it will start September 2023. And this came up, I think, in maybe April. And okay, so we have some people saying keep him until he fails, right? Keep him on the same regimen. If Ian broken, why fix it? Okay. So most people are leaning towards keeping him right now. Okay, so Yusri says yes. The doctor is in the house.
Hello. Hi.
So what do you think, Yusri?
I have no idea, but that's a short period from September to now. I mean, we know that maybe only the M84V has got some data about the decay of it. So if you've got someone who's got a an archived N184V, and then they stay suppressed for 10 years continuously, maybe the content that is there in the whatever sanctuaries are probably gone. So there's preliminary data about that, but I have no idea how long the integrase mutations will stay for. 2013 seems like a lengthy period of time. Of course, we don't know what happened in the interval between that time and now, but again, from September, is it you said September 2023?
Yeah,
To
September
April
2023 to, let's say, April.
to
So
April.
maybe,
So it's
yeah, 6 months.
I have no idea, but I think 6 months is just about pushing it. And if he's gonna fail, probably he's gonna fail now. So yeah, we'll just not try to fix it. I don't know though.
Yeah, and we just couldn't really figure out what to do, honestly. Like, we have 3 full-time providers in our HIV clinic and a pharmacist, and there was kind of a back and forth. Should we switch? Should we not? But I think all of us were like chickens, so to speak. We're like, no, we don't want to take the risk, because if he fails, if he fails cabotegravir, he technically already failed. So it's not like we're gonna switch him to bictegravir, right? So we kind of
But
almost
Nada, he's been suppressed for how many years now? Fully suppressed?
He's been suppressed, yeah. And
For how many years?
was 20
Because the 2013.
no, 10 years, yeah, 10 years.
10 years. Yeah. So yeah. If
Yeah,
he's been suppressed
for 10
for
years.
if it's been suppressed for 10 years, maybe more, maybe, who knows, it may have gone. But yeah, if
That's a
it's
really
less
good
than
point.
that, it would have been more work.
Yeah, that's a really good point. If he's suppressed for more than 10 years, God knows what happened to that. Or it could be, there are some always errors with genotypes, even though they're rare, you always have to keep that in mind. But his history also was kind of worrisome, because he did tell us that I have been on many medications and I had extensive resistance. Although knowing when integrase came to the market, the early resistance in the early 2000s, those would not have been integrase anyway. Those would have been NRTIs or NNRTIs. But yeah, I think.
So can I ask a question?
Yes.
Yusri, what do you mean by gone? Like, can you get rid of a
Hello, Radar.
Yeah.
The long living memory cells that are there in in the tissues and things like that. These are the cells that have got HIV that is archived in them, and this is where the virus come out from when we stop the antivirals. The viral load increases. So if there is an archived species of or subpopulation of HIV that carries some mutation, it will be there. But these are such long living cells, but their half-life is 10 years. So when they die, the virus within them will die.
Okay. Lovely. Makes sense now.
Yep. So would they emerge, for example, if we wait would they completely like disappear? Nobody really knows. But you know, we felt like we have room, we have other options, so why take that risk? He actually, we were really worried to have this conversation with him. We're like, we're going to present him the options. We'll make a shared decision making with the patient. We'll say we wait, we keep an eye on you, maybe check the vital load every time you come in, every 2 months for your injection. We'll check the vital load. The minute you start creeping up, we'll get a genotype and we'll switch immediately. Or we go ahead and switch now. We have other options. The problem is that you're going to go back on pills, right? And who would want that after the venom injections, right? So most people getting an injection 6 times a year, that's a huge convenience. So why would you want to go back to pills? So we kind of knew when we go to him with this presentation of shared options, he's probably going to choose to stay on the injection, and he's probably going to be really adamant about that, because people who came from this provider were very stuck on staying on the injections, regardless of what the other issues are. So, and at that time we will feel better, because then this is a shared decision making, the patient chose so, and we can just wait and take a case. But we actually brought the other option to the table too. The other option would be to switch to medications, to pill medications, a PI containing regimen that will, you know, to get rid of this problem. And surprisingly, the patient was like, off the bat, he said, yeah, switch me to pills. And we're like, yeah, but you know, there is another option. He's like, no, I'm fine. Just switch me to pills. So we did end up switching to a PI regimen. And I believe it was like Simtuza, which is boosted darunavir, anthracycline, tenofovir, plus doravirine. But I did not actually mark that, and I'll have to go back and double check. But that's basically what happened, that we ended up switching him to pills, and he's doing perfectly fine on the pills. But the other option, honestly, too, that we didn't push strongly at the time is getting an archive testing. Like Yusri said, if these are not present in the archive, if he does not have rilpivirine resistance, did we really need to switch him? That could have been a very good third option. And we have time, obviously, with him. There's no urgency to make a decision because he's suppressed. He's doing fine. So when we presented the options, we didn't really put that option on the table, which I think was probably a mistake that could have solved some of this dilemma. Now, again, if it's not present in the archive, is it completely not present? It's kind of up for grabs, honestly, but it would give us some reassurance that if it's not present in the archive, we may have not to worry about it. So this is, now I know that people from the UK all think alike, because this is exactly the case that was challenged at ASM. And when I said we switch him, immediately somebody raised their hand and they're like, why did you switch him? You should have probably just left him alone. And I'm like, yeah, we probably should have, but you know, we ended up switching him. Maybe in the future, we're going to have some much better options in the future than caprilpivirine. So it's not like injections are completely out of his future. And this is, I think somebody asked about fostemsavir earlier. So this was a table that was presented at the AIDS, actually, AIDS 2021 figure presented about fostemsavir resistance. So fostemsavir basically is, I think the best way to describe it is an entry inhibitor, and it works at the GP120. So remember the glycoprotein 120 and CD4 counts, or CD4 cells attached to the GP120 region, etc. So it doesn't work at blocking that GP120. So if there is substitutions at GP120, then there is highly likely that that's going to affect the drug entry, right? Or affects the activity of fostemsavir. So in that case, fostemsavir will probably not work because it changes the conformation of G120. So the studies that looked at fostemsavir, when they went back and looked at what caused decreased susceptibilities of fostemsavir, it was found that substitutions at these positions of GP120, 375, 426, 434, or 475, those were associated with decreased susceptibility. But like there have been cases also that had these substitutions and the patients did okay on fostemsavir. So it was like, we know these can probably predict, but they're not 100% predicting, because some patients do okay with fostemsavir even in presence of these substitutions. So there is basically no consensus right now on whether, first of all, we should check for mutations before starting fostemsavir, or if the patient is failing fostemsavir, whether you should just check for that or not. Because honestly, if you check, what do you do about it? Like, you're not going to switch to another GP120 entry inhibitor. but it's not like that's an option. So basically, nobody really checks for stem severe resistance, either before you start or after. And no, these are not really mutations by the meaning that they're caused by selection. These are pre-existing phenotypic changes at the GP120 position that predict susceptibility to stem severe. So if you already have these changes, then you technically should not use stem severe, but when it was used, not knowing those changes are there, people still did okay. So that's why it's kind of up in the air. Nobody really checks for stem severe resistance before you use it. You just use it. If the patient does okay, great. If the patient doesn't do okay, you switch. Maybe to lenacapavir in that case, which is one of the newer drugs that are available in the market right now. And unfortunately, I did not include a slide on lenacapavir, but it's a newer class of medication. It's a capsid inhibitor. So what it does, it works at the last step of the HIV virus assembly. So you have, the initial steps, entry, integrase, and then you have reverse transcription, and then you have protease. And then the last step is to assemble the capsid of the HIV virus. So this prevents the capsid assembly, and it basically kind of terminates the cycle right there and then. And it's a very nice, potent drug. It's 6 monthly. So again, has a very nice convenience to it as well. There are some mutations that can cause lenacapavir resistance, but there is also no consensus about checking before starting lenacapavir, because, again, if you're at that last resort, you probably just don't have many other options anyway. You just have to use it. So we don't routinely check for lenacapavir in clinical practice. In research settings, it's a different story. But it's a very nice option. We actually have started somebody on it last week for the first time in our clinic. One of our providers went ahead and started somebody with lenacapavir. And I don't know the full story, but that would be a nice discussion for our next resistance testing lecture, is to talk about these newer drugs, stem severe, lenacapavir, because it's going to be the future of what we can do. So, okay, so somebody I think is not on mute. So in general, the take-home points are very easy, straightforward. So resistance is still a challenge, even in the era of modern ART, because we have patients who lived a very long life. They have been on regimens in the past. We have patients coming in with transmitted drug resistance. There is the issue of pre-treatment drug resistance, which we sometimes mistake as transmitted, but they're actually pre-treatment because somebody has been on treatment and didn't tell us. And these are all things to keep in mind that might add to the complexity of this topic, yet straightforward, honestly, now, because the medications that are available made it very easy to manage most of these issues. Now, instant drug resistant mutations, whether selected or acquired or transmitted, they're very rare still. So usually they happen after multiple failures. They don't happen after first-line regimen. So if somebody fails, like the patient we presented earlier, what looks on the surface like first-line regimen, and they do have second-generation INSTI resistance, that's an issue. And you have really to question yourself and go back and take more history. And majority of the time, there's something missing, like this patient we mentioned. And then careful review of resistance testing before initiation of long-acting ART is really needed. In this case of the patient that we had, if we had reviewed that resistance, maybe we wouldn't have started him on long-acting ART. And maybe it was good that we started him, because now there's a challenge out there. Does this really even matter or not? Something to worry about. And then resistance of lack of adherence usually is a manifestation of deeply rooted systemic issues. So many times we just think mostly about the medications. What am I going to switch this patient to? Like the patient that we presented earlier, he had multiple resistance, multi-drug resistance. We switched him to Fostemsavir, like a kind of innovative newer generation. We were excited about that, but we really didn't address the social issues that led him to develop resistance. He was incarcerated. He had to move from one city to another. He had issues with homelessness. He had issues with insurance. We did not do a good job, even though, we tried our best in the clinic, but we didn't solve those issues. Some of them are beyond our reach because they're systemic in nature. But because of that, now he's lost to follow-up. He's probably not taking the Fostemsavir, or maybe he's taking it at subtherapeutic level and he fails the Fostemsavir as well. So just when you address these issues, don't forget about the social issues, because if you do, then you end up with more resistance in that same patient and eventually in the community as well. So I'll stop here and see if anyone has any comments or any questions.
شكرا like this is really great. This is really great. Thank you.
Oh, you're welcome.
Thank you, Nada. That was fantastic.
Thank you
Nada,
very
You're
much,
welcome.
Nada. Thank you very much, Nada. I logged it at 5 and then I logged it at 6 and then at 7 something happened. So I was planning to be there from the beginning. So I missed maybe the most important part of it. But I'm gonna watch it.
Yeah, no problem. I know like weekends can be crazy as the dean is on call as well, but I'm really glad that everyone joined, and thank you so much everyone for the thoughtful contributions and the back and forth. And maybe next time I see a patient doing well on long-acting injectable, even if they have pre-existing resistance, maybe I'll just toughen it up and see what they do. But this was our first experience ever, and we were like quite intimidated, honestly. We didn't just kind of feel comfortable, but I think now I have a little bit more of confidence, especially after this discussion and seeing that so many people would be like, just let's wait, let's see how it goes, which we do a lot with ART anyway.
Yeah.
Yeah.
Yeah, well, Nada, we benefit from this. I mean, this case is specifically, and any case that you see in the future, because we're just like really now starting to use these injectables, and the experience is quite limited. So yes, please keep these cases for us, and inshallah for the next resistance talk, then we can discuss them further.
Yeah, absolutely. And I would love to do a joint talk, maybe you three, to kind of just see the differences in practices, like
Yep.
present cases from the US and from UK and from
Yep.
other regions, the Gulf,
Yeah,
etc.
I think we should bring in cases. Yeah, real cases.
Yeah.
That
Yes,
would be enough.
that's a good
Yeah.
idea as well. Yeah, Nada.
Yeah, we could just do a case-based discussion and we bring the cases and discuss them over. Because sometimes, honestly, you just like programmed to think this way because your colleagues, your friends around you, that's how they approach things. But when you get challenged by different audiences and different groups, you get to think deeper about the issue. Is this really an issue or not? So. All right. Thank you, everyone. Have a wonderful rest of your weekend.